All right, good afternoon, folks. Thank you for joining us today. I'm gonna start briefly introducing everything because it's a pretty hefty topic where we're trying to tackle today. And it's probably one of the more challenging topics I find as a sleep physician for two reasons mainly. One is the fact that with insomnia, most people actually struggle with this for many years. They've tried, they've attempted to deal with this on their own, and they're awake most of the time. So they've got their thoughts, they've got ideas. They've tried buying expensive beds, pillows, tried Benadryl, over-the-counter concoctions, herbal remedies, and nothing's really worked. So they come in with a fixed idea, they're frustrated, they just want a fix from you. And so that's why insomnia is difficult, because patients come in with a preconceived idea of what they need, and it's the second component is also what makes it difficult is the time that requires. So when you have a waiting room full with many patients, dealing with insomnia is a little bit more challenging. So that's the reason why we're trying to give you all some of the tools, or at least share some things that we've learned along the way. And so let's get started. These are the terms of use, a disclaimer, just use your clinical judgment. And I'm fellowship trained. I did a few years ago, and I must say it has made me a better pulmonologist as well. And I think a physician overall, just recognizing some of these sleep issues and being able to deal with that for a lot of my patients. I think that has really been something I owe my mentors a credit to, because they're the ones that strongly suggested that I add sleep medicine as an additional certification or a fellowship, which was a painful additional year after 6 years of fellowship training. But I must say it's probably given me the most amount of gratifying or feeling of doing good for my patients. Now, this content is without any sort of obvious conflicts, except the fact that it is my practice that I'm running this through, and it's a virtual sleep medicine practice and a pulmonology practice as well. So we do everything from evaluation to testing and treatment of patients. And we're licensed in several states. But again, these topics are all we're not selling any sort of insomnia products over here. Now, to get credits for this, it has been approved by the American Association of Nurse Practitioners. I recognize that many nurse practitioners are coming out and helping the healthcare workforce that we have, and adding to the number of providers that we have, and actually touching many more patients than a lot of physicians can or are able to. And so this is kind of giving you some of the tools as well. And again, there are physicians as well attending, kind of giving you tools to how to recognize sleep issues, how to manage them if you can. But I think the most important thing is the awareness of it, the recognition, and we'll talk about how it impacts health overall as well. But to get your education credits, we will provide you with a post-webinar test that you can do that will be released within a few hours of this webinar. And once completed, we will issue you a certificate. The webinar test, or the post-test webinar, will be closed 1 week from today. So you do have time. We also include a video of this recording to ensure that you are able to review it. Again, like I said, it's a pretty hefty topic. And so what are we going to cover today? The pathophysiology. Now, whenever I heard pathophysiology in med school, my eyes rolled back, because it's a whole lot of stuff that I didn't feel I needed to learn. So I'm going to try to distill this down to you, just to really give you some of the tools that you will need to recognize why insomnia comes about, why it's both a symptom and a disorder, and then trying to figure out what the consequences are of insomnia on health. So whether you're a nephrology nurse practitioner, or a nephrologist, or a cardiologist, or if you're dealing with endocrine and endocrinal, or you're an endocrinologist, for example, or a psychiatrist, or have a background in psychology, how insomnia affects your patients, we will kind of delve into that, even a pain specialist. Then beyond that, how do we evaluate patients? Really, how do we put all this information together and go, okay, now how do I help my patients? Enough of this pathophysiology, enough of the consequences of increasing this risk and that risk, but how do we actually execute on that? So that's where I think we'll dive into and give a little bit more time on. And also discuss prescribing strategies, because again, patients are going to come to you, and I'm not going to sit here and tell you, well, you have to kind of go through this evaluation and that evaluation before you give medications, because really your relationship with your patient is a personal one, and I want you to know that. And at times a patient comes to you and they do need help in terms of their sleep, and you should not feel like prescribing medications to them is something you shouldn't do, or you feel like, oh, I have to wait before I do all these steps. Sometimes you might need to start medications and work on the CBT or the cognitive behavioral therapy issues along the way. But the first step is to recognize that sleep may have an impact on your patients, recognizing that, asking the questions, prescribing what you need to prescribe while working with them to get over it, so that you don't create a monster in 5 years, 6 years, even a few months, in terms of patients who keep coming back and calling you and asking you for prescriptions because they don't think they can ever sleep without medications. Now, you will have a small number of patients such as that, but I think if you go through some of these steps we're going to discuss, you'll find that those number of patients actually is a lot smaller than we imagine. Plus, patients don't want you to take their medications away from them. So once you start that, you've created that, you own that. All right, so what's insomnia? Insomnia, the definition has become way easier. That when I was in training, there was primary and secondary insomnia. There was all these things that made it so much, I guess, complicated. But they've distilled it down to the latest guidelines. Actually makes it a lot easier. So the first few things is just actually difficulty initiating or maintaining sleep. So a patient says that I can't fall asleep, I wake up a lot at night. These are complaints that I frequently hear with insomnia. The next thing you need is adequate opportunity, meaning that you actually need to have a window of sleep that allows you to get adequate sleep so you feel better in the morning as well. So the opportunity of sleep has to be there. Circumstances, meaning the environment, meaning it's a cool, quiet, comfortable environment, and that needs to be there as well. Sleeping in an on-call room in a hospital may not fit that bill sometimes. Coming off night shifts also is also coming back home to a full house to deal with, and so on, may not present itself as adequate opportunity. Daytime consequences, what really affects the patient. Now, sleep is one thing, but a lot of sleep is something that patients think is passive, that I need to get through before the day starts. But the consequences of poor sleep actually is what we deal with for 16 to 18 hours in a day. So what are the daytime consequences? And you will recognize many of these daytime consequences affect your patient. The fatigue, the malaise, the sleepiness, dementia type symptoms with attention, concentration, ADHD, patients with very poor ability to maintain jobs, for example, or relationships, mental health issues that you just can't seem to get a grip on, patients who can't stay compliant with their medications. All these may have an origin in actual poor sleep. Reduced motivation. So that's how a lot of sleep in terms gets mixed up with dementia, or poor sleep tends to perpetuate issues of depression and mental health issues. Because if you look at the reduced motivation and initiative, all of these are also what we call overlapping symptoms with a lot of these other diagnoses that we come across. And we frequently have a sort of a toolkit that we're comfortable with when we're in training and when we come on in practice, and we tend to use the same toolkit over and over again. Someone comes to you with low energy, you do a depression screen, or they come to you with low energy, it's a guy, you do a testosterone screen, you do a TSH screen, and ooh, wow, you find that has issues with testosterone, you give testosterone shots, you improve some of that, but you don't really help the underlying problem. So you'll recognize a lot of your patients over here have daytime consequences from sleep, and they actually tend to mimic a lot of other disease processes. So if you see your patients, whether it's a nephrology patient, whether it's a cardiology patient, whether it's the patient with mental health issues, recognize when things start getting out of control, that what you're doing for them, they're not following through, or you're not having the desired impact on the outcomes, the blood pressure control, their mood, and so on. And that's when you have to start saying, is there something else burning or flaming fueling the flames of that fire? We've also kind of, and I say we, I'm not the guy that came up with this, but I appreciate that there are people smarter than I that have come up with these definitions. So the definition, like I said, it's about initiating sleep, maintaining sleep, the daytime consequences, and having adequate opportunity. So then insomnia is broken up into two further pieces, which is acute insomnia, which is something really short-term, circumstances related, whether it's an exam, whether it's a caregiver, whether it's an acute illness. And at this time, I think it's also whether it's jet lag, for example, these kind of things, daylight savings time. You can treat with medications in short term and actually work with the patients to come off it as well, knowing full well that if their exams coming up and they have high anxiety levels and so on, this is when medications are going to come in quickly and then leave the scene quickly as well. You work with the patient, have an understanding that this is what we'll do for short term, and we'll try to get you off the meds soon after. Chronic insomnia is where we start kind of what this talk is really about, is where we start working through about what the issues are, what the precipitating issues are, what the perpetuating issues are, trying to figure out how to actually get them better sleep long term. And this chronic insomnia is what really affects a lot of patients long term. Now, insufficient sleep, and this is where the circumstances or opportunity of sleep is important, is to make sure that patients don't mistake insomnia for insufficient sleep. So with that being said, patients need to be able to have a good window of sleep, whether it's 7-8 hours every night that they dedicate to sleep. And sleep is not just an afterthought once they get over with their actual lives during the day. How you do that is ensure that you tie in, when a patient's sitting in front of you, to tie in how their sleep may be affecting all the other reasons why they're sitting in front of you: their diabetes, their blood pressure, their mental health, all these other problems, their sugar control, their energy levels. Is to tie in how insomnia affects it, and kind of giving them, ensuring that they understand that the crux of good health, despite in addition to all the medication that we're giving them, actually relies on 3 fundamental issues. One is good sleep, mobility, and good nutrition. And make sure that you tie those in, especially when you're talking about sleep, tie that into how that affects all the other medical problems. And that allows them then to actually focus on giving themselves an adequate window of sleep. Patients have unrealistic expectations at times as well. Some patients will say that the number of times I've had to stop myself from rolling my eyes at the back of my head when I hear a patient say, I have not slept for 5 days. And I'm like, okay, all right, this is going to be a tough one. Most of the time, you would have undergone a psychotic breakdown and be admitted to the hospital after 3 days of not getting enough sleep. 2 days already, you're miserable and you can't even function. You're drunk in essence in how you function. And so, that patients tend to underestimate the amount of actual sleep they have, but that's because of the frustration they've had with it and how long they've had this problem for. Now, also the other thing is brief arousals. Patients waking up a couple of times a night is not abnormal. It's well within normal reason, except that they need to be able to fall asleep pretty quickly, within 5 to 10 minutes. They need to toss and turn, they wake up, they should be able to fall asleep. They use the restroom, they come back, they should be able to fall asleep. If they're staying awake for 20, 30, 40 minutes, that's when you want to kind of address those issues. And there will be variation with age as well. But again, patients still need that more than 7 hours of sleep. And sometimes that unrealistic expectation as well. Some patients say, well, I read 8 hours of sleep, so I need that 8 hours of sleep. So I'm going to go to bed and give myself 8 hours. And I go to bed and I'm not going to sleep. If I don't sleep within half an hour, I have a problem now. And I'm not being able, I read in the New York Times that it increases your risk of heart disease. And I'm not getting in my 8 hours sleep, doc. I need my 8 hours of sleep. So there will be variation individually based on age, based on medical problems that you have as well. So it's to make sure that we will talk about this in stimulus control in terms of how to deal with that, but understanding how that expectation can sometimes lead to insomnia. Unrealistic expectation can lead to insomnia. So what regulates sleep? And so what we want in most patients is actually the culmination of 2 things. One is sleep drive, which is what you accumulate as you wake up and you do things. You're active, you're thinking, you're talking, you're socializing, you're moving around, you're commuting to work, you're picking up your child from daycare, you're managing your household, you're going shopping. All these things are accumulating your sleep drive, and that's what's going to make you sleepy at night. Now, when we do less of that, you accumulate less sleep drive, so it might change your ability to fall asleep. And we've seen that. I've actually, surprisingly, I've started seeing a lot of that as patients now work from home more often. So they're not going out. They're not exerting themselves the way they used to. They can take a short nap in the afternoon if they want to. That all affects sleep drive. They're sitting in front of they can, they've got a fridge full of food. They can keep hammering away at their energy drink. So this affects their sleep drive. So the sleep drive, as you can see here, needs to meet their circadian drive. And that is when you wake up and you get exposure to sunlight. So getting out of the house, doing things, making sure that your mind activates or your eyes receive that signal of light that really starts your clock going. Because once your clock starts your wake clock starts going, you've got about a good 16, maybe 18 hours of good wake time before you start crashing. And that's when your sleep drive has to meet with your circadian drive. So that's why sunlight exposure is important. Again, working from home can affect that a lot. Patients are staying in, they're on their couch, they're working from their laptop, they love it, but it also deprives them of what actually keeps their sleep drive. So they're kind of like in a twilight zone. If I were to use an analogy, it's like the same problem we have with hospital patients. You have them in their room, they don't have any sunlight, they end up taking naps during the afternoon, they're on medications for pain, they're on some other medications as well that increases their likelihood to feel fatigued. They end up taking naps throughout the day, their sleep drive is affected, they're not getting out as much, they don't have as much light exposure, and then you end up having a lot of patients with a lot of issues at night, sleeping and so on. Again, when you take that to patients at home, they're going to try to fall asleep. Now, their routine has always been to sleep at 10 o'clock. Now, if you don't have the circadian drive and you get to sleep in a little bit because, hey, I don't need to have that hour-long commute to work, that circadian drive is not going to meet that sleep drive. So then they get to sleep in a little bit. Their circadian drive starts at, let's say, 8:30 as opposed to 6:30 previously. But they always previously they used to go to sleep at 10:30. Now, when they get into bed at 10:30, they actually just woke up at around 9 or 8:30 in the morning. So they've had only maybe 14 hours of actual wake time. They've been at home, they've not been exerting themselves. And then the hour that they're in bed, ruminating about why I can't sleep, what's going on, why is this a problem? This is what perpetuates a lot of the insomnia as well. As you get older, there's a higher risk that we've seen. Female patients also tend to have a higher risk of this. Now, I can't say for sure whether it's just that they're more likely to get it versus not really complaining about it or getting treated for it, because a lot of times insomnia is a complaint that women make compared to men who complain of daytime sleepiness when it comes to sleep apnea. So a male patient may come in and complain of well, my partner brought me in here, forced me in here at gunpoint to make sure that I told you that I snore. And I'm feeling fatigued or I'm feeling sleepy during the day. But a woman may come in and complain about the fact that I can't stay asleep or I'm not getting refreshing sleep. And so that's why at times women may get treated for insomnia when they have another underlying medical problem as well. Shift workers is a common issue. We have close to, I think 25% of Americans at some point have some sort of shift work that they have to do. And I used to do some night shifts, and I can tell you it's not a great existence. Coexisting medical problems, psych problems also increases your risk. Now, we need to understand as well how these things occur. So we have this model of therapy called cognitive behavioral therapy. It's a combination of two things. One is cognition, meaning the thoughts that you have related to sleep. But these thoughts related to sleep also affect your thinking during your daytime of a lot of other things, how you deal with stress, how you deal with issues, how you deal with social problems. So the identification of all of this is actually goes under this umbrella of cognitive therapy. The behavioral therapy is the actions that we take, things like when we get into bed, what we do, and so on. Now, what cognitive behavioral therapy as a therapy itself is a lot more, is a deep dive and done by therapists, skilled therapists, and I have a lot of respect for them. And I hope if there's anyone on here that has any background in sleep psychology, they don't think I'm butchering this part of the talk. But in my training, we had to sit with psychologists and psychiatrists, kind of deep dive into this, and hats off to their skill set in terms of extracting how patients think about sleep and how actually their daytime functioning and how their daytime thought processes actually mimic and go on to affect their sleep at night. And working through all those thinking and unfolding all those issues is something well beyond the scope of this talk, but it kind of is something that I want to touch on because this is how part of therapy for insomnia is. So you identify triggers, you assess the patient, and then you kind of start working through each one of them. And this is done over a 5 to 8 weekly sessions that occur, sometimes even longer. And so it's exhaustive, and I don't really have the time for it, and neither most of y'all as well. But the good thing is, at my practice, what we do is we work with one of the first few FDA-approved CBT, or cognitive behavioral therapies for insomnia apps that's FDA approved to treat patients. So you e-prescribe these therapies. So even if you don't have access to a psychologist or sleep therapist, there's help now that's so much easier that can be done over your cell phone. But CBT is just the overall model that we look at and how we deal with insomnia as a problem. Now, the Spielman's model over here looks at as well that we look at how patients start off with insomnia, how it starts off. So a lot of the cognitive part of it will deep dive into the predisposing factors in these patients, and then touch on the precipitating and then work through the perpetuating. But you and I, as general practitioners who don't have the skill set to deal with this, our focus really will be on the perpetuating factors, factors that the patients now have started doing, which strengthens or solidifies their issues with sleep itself, or causes insomnia. The precipitating factors may be something you want to do. I do a little bit of the precipitating factors, like going back into what caused it or when they started noticing these issues. And it's trying to figure out how that relates to what they've done now, kind of getting a timeline of, oh, I've tried this, I've tried that. This was an issue. I got a sleep Serta bed number 5. I'm not sure what numbers they are, but they've spent all this money and they've tried this herbal remedy and so on. So you want to get an idea, because what you want to do is then explain to them how all these things actually getting back to what are the perpetuating factors that they're doing right now that may be actually causing them to continue to have insomnia. For example, one thing would be, I have to go to bed by 10 o'clock at night because my partner goes to bed. Or I have to go to bed at 10 o'clock because I need my 8 hours of sleep. And so these are some of the things that will initially, when you extend your time in bed, you want to make sure that you have that. So that can actually be a perpetuating factor of why you perceive or why you have insomnia. So now let's talk about the consequences of sleep. What are the consequences of sleep? So now we understand what drives sleep, what causes insomnia as an issue. We have things like we talked about, the pathophysiology, which is the circadian drive. We have the sleep drive as well, that causes a lot of the issues. What may be some of the precipitating factors? What are the perpetuating factors, your risk factors in terms of other medical problems? So the background about insomnia we've touched on. Now we're going about how insomnia manifests themselves in your patients. Patients may be self-medicating. I have family members who self-medicate with alcohol and refuse to listen to what I say. So I can understand why patients don't want to listen to me as well, because if you don't listen to your own family members, it's hard to assume that you're going to have that success with a patient. But yes, so self-medication is one thing, whether they're taking benzodiazepines, whether they're using alcohol, whether they're using other sedatives. Self-medication is a consequence of insomnia that we deal with a lot. Injury is a workplace problem, is a safety issue, whether you're in healthcare, whether you're managing a factory, whether you're a machine operator. These are obvious things that we need to be aware of as well. Poor quality of life. It's a crappy existence having poor sleep. You'll be surprised the number of patients that have been dealing with poor sleep by the time they get to me, and the years and years and years of problems they've been dealing with. I'll give you an example that really struck me the other day, and I asked a patient this. I was evaluating of a sleep apnea, but I just asked a question that I normally ask. I said, how do you feel tired when you wake up? And she just looks at me and she just says, well, how else are you supposed to feel? And that struck me. I couldn't tell whether I couldn't figure out whether I needed to laugh at that point or cry at that point for this person, because I've been dealing with a newborn this past week and I've had poor sleep. And I can't imagine how a human being goes through this for years and years and years. So the quality of life really gets diminished if we don't address this. And then we start seeing the effect that it has on other medical problems as well. Which brings us to mental health. We're seeing a huge spike in patients who have poorly controlled mental health, where we have a whole lot of medications to sedate patients now, benzos, non-benzo drugs. We have antidepressants, anti-anxiety medications. But in actual fact, if you don't treat the insomnia, so that's why I talked about the definition of insomnia had made so much easier. Previously, it was divided into primary and secondary insomnia. So you treated the primary insomnia with medication. The secondary, you treated, if it was related to depression, you treat the depression first, and then you see if you still need to treat the insomnia. But now that we know that the effect, they have a bi-directional relationship, meaning that if you don't treat the sleep issues, your mental health gets worse. You don't treat your mental health, your sleep issues get worse. It affects anxiety as well. When you don't get poor sleep, the body's in a heightened state of stress. And that heightened state of stress increases your sympathetic drive. Your sympathetic drive triggers your tachycardia, triggers your anxiety, triggers your mood disorders, triggers your irritability, triggers your atrial fibrillation, triggers your restless legs, triggers your blood pressure control, triggers your diabetic control. So you can see how that manifests itself over and over again. And all we end up doing in the clinic, in the office, is to keep increasing their blood pressure medications, keep increasing their diabetic medication. And we keep saying patients are non-compliant, they're not following through. But in my experience, most people want to feel better. And if they're not following through, there must be something else. And so the next question that I really want to impart upon y'all is to ask why these patients are feeling this way. Why your diabetic patient, why your nephrology patient, why your cardiology patient, whether they came in with heart failure, why is it not controlled? What else is driving this? I've given them the medications, the standard therapy, I've done all of this, but I keep losing this battle. What else is going on? This talk is to kind of trigger that question. And this whole series of webinars that I'm doing is to trigger the question, is sleep driving some of these problems? Now, what is short sleep length, or at least insomnia, in terms of not getting enough sleep? How does it affect you? It increases your risk of heart disease, blood pressure control. In my first webinar, we looked at this graph that actually charts across a 10 to 12-year process about how if you have 5 hours of sleep, the amount of weight gain that you have compared to if you have 7 hours of sleep, you may have a much more flatter curve as you age. But how weight gain is affected by insomnia as well, how dementia is affected by insomnia, how aging and mortality is increased. And the one thing is not to impart on your patients like, holy cow, if you don't get enough sleep, you're going to die of heart disease, is that how insomnia is affecting heart disease, how insomnia is affecting your quality of life, how do we treat that and evaluate that? So trigger the thought first of how sleep is affecting a lot of medical problems, and then start asking those questions. Now, insomnia exists with many other medical problems, psychiatric issues, which we talked about, your heart rate, your heart control, heart rhythm control, pain issues. Pain perception also has a bidirectional relationship. Pain affects sleep. Now, poor sleep increases your perception of pain. So you end up having this issue of increasing their pain meds. Now, what you don't want to start telling your patient is, oh, well, I'm going to stop your opioids because I'm going to help you sleep better. You're going to have a patient who's probably not going to see you ever again. So you don't have to worry about that, I guess. But the one thing you have to worry about is that you haven't really helped them. So I generally, with pain patients, I don't want to take their medications away. I explain to them how sleep or better sleep and why I'm asking these questions affects their pain. Because if pain continues to be an issue and they keep ramping up the medications they need, it's going to be a losing battle. And then once you increase your dosages of pain meds and so on, you end up increasing the risk of poor outcomes as well for these patients. How insomnia also affects other sleep disorders, or how other sleep disorders coexist with insomnia. So there are still a lot of comorbid conditions that exist with insomnia. And so, like I said, the restless legs, how it manifests, circadian rhythm. And circadian rhythm is whether it's jet lag, and sometimes there's something called social jet lag, which I love talking to patients about because it's something I have and I know exactly how it works. You know, you'll sleep like clockwork on a Monday, Tuesday, Wednesday, Thursday, and then Friday comes around and you're like, "Ooh, I can go out, I can have a few drinks, I want to stay up till 12 o'clock." And before that, you were sleeping at 10 o'clock. So for the next 2 nights, you're a hero and a champ, and you're sleeping at midnight, and you're waking up at 8:30. Now Sunday comes around and you're like, "Oof, I need to get to bed by 10 because tomorrow I have work." And guess what? After the last 2 nights, I'm going to sleep at 12. You're not really going to be able to sleep at 10 o'clock the next day. And that's how the insomnia tends to perpetuate itself. Comorbid sleep disorders as well, comorbid psychiatric disorders is like we spoke about how poor sleep affects psychiatric illness, and psychiatric illness affects poor sleep. But beyond that, as well as the medications that the patients take. Some medications may have an activating, sometimes a sleepy or a sleepiness onset. So it affects their mood. Now, when you take medications that take away your drive or sedate you, guess what? You're not going to be as active and as or ability to kind of go out and increase that sleep drive, because all that activity that you have during the day is what actually improves your sleep drive, so that when you do hit the pillow at night, you are able to fall asleep. Some of these medications will sedate you and take away that sleep drive, or force you or want you to take a nap during the afternoon. And that takes away your sleep drive as well. So the effect of medications on sleep is huge in a lot of the patients. Comorbid chronic pain. So we spoke about that as well, how it also has a bidirectional relationship. So you don't want to start the conversation about taking the pain medications away, but explaining the relationship and how better sleep actually improves pain outcomes as well. And we've looked at how CBT as well, CBTI, cognitive behavioral therapy of insomnia, how that itself can also found is effective to help with sleep and pain. Other comorbid sleep issues or medical issues, cancer is something to treat because you want to improve. If someone has cancer and they have reduced lifespan, you want to make sure that whatever life that they have left is of good quality so they can enjoy their day, not to be spent in doctors' offices, but to enjoy that time with families and friends. How heart failure affects their sleep as well, how reflux affects their sleep. Nocturia, I've put that down there as well, because a lot of times that is affected by medications. It's also affected by sleep apnea. And so you want to look at other comorbid medical conditions or sleep conditions, but you also want to see how you're prescribing your medications and that affects your patient's ability to fall asleep. So please, if you're going to prescribe furosemide twice a day, make the second dose 6 hours after the first morning dose and avoid the evening dose, which is going to keep up a poor old lady and an old man awake at night going to the restroom, increase their risk of falling and fractures and so on. All right, so we've spoken about the circadian rhythm and the sleep drive, about insomnia. We've looked at how the perpetuating factors continue to manifest patients' issues with sleep, the comorbid issues that exist with insomnia as a consequence of insomnia, how it affects whether you have diabetic issues, whether you have heart disease issues, high blood pressure issues, mental health issues, all of these issues, low energy, low T, for example, patients come in with low energy. And so how insomnia is something that we need to make sure that we understand how it affects our patients. But now let's deep dive into some of the areas that we can actually impact the outcomes and help them. How do we evaluate a patient? So like the diagnosis or the diagnostic criteria I had mentioned earlier, understand what the sleep complaints are: difficulty falling asleep, difficulty staying asleep. What is their issue? Are they waking up feeling refreshed? Are they waking up dragging in the morning? Are they waking up multiple times at night? Are they able to fall back asleep again? What time do they wake up? What time do they go to sleep? How do they go through the day? Do they need a lot of caffeine? Are they likely to take a nap during the day, or would they like to take a nap if they could? What sort of impairments do they have? Mood disorders, whether they've had abilities of they're not taking the medications because they forget to, they're forgetful, they've had increasing irritability, they've gone back to their psychiatrist twice since they last saw you because they've had increasing mood problems and so on. So all this associated impairments need to be assessed, because that gives you an idea of how serious you need to take this and kind of set time in your consultation window to ensure you address that. Precipitating events as well. But like I said, the precipitating events, if you're dealing with a patient and you're not a sleep specialist, I'd say the perpetuating factors is what you want to look at. What time are they going to bed? What time are they being able to fall asleep? Why do they go to bed at 10? Why not 10:30? If someone comes in and says, well, I sleep at 10, but I fall asleep, I get into bed by 10, but I fall asleep at 10:30. The question next should be, why do you go to bed at 10? Why not 10:30? Is there a reason? Oh, I've always gone to bed at 10. Oh, my favorite show ends at 10. Well, I guess that's no longer a reason, since you can Netflix any time of the day. All right, maybe not that anymore. But you can look at things like, oh, my spouse goes to sleep at that point. But every individual has a different circadian rhythm and a different sleep drive. So that may need to be matched appropriately as well. So what are the perpetuating factors that this patient has? Environmental factors are somewhat important. I don't really delve into that as much, because whether it's a dog or a cat in your bed, the patient's not going to change that. Most of the time, the patients already are smart enough to already have set up a quiet, cool, dark environment. They've already spent a lot of time thinking about their sleep at this point. And so the environmental factors are usually, now what patients will tell you, and I've heard many times, is that, oh, I'm a light sleeper, I hear everything at night. Well, there are very few people that are pathologically light sleepers, meaning that they're just purely light sleepers and they don't get into deeper sleep like stage N2 or N3 sleep, or even a REM sleep, and just stay in the N1, N2 sort of back and forth, which is light sleep. Now, there's very, very, very few patients like that. Now, what actually ends up happening is that they have an underlying sleep disorder that doesn't allow them to actually get deep or slow wave sleep and deep sleep, such as REM sleep as well. And that's what actually they're complaining about, because they will swear by the fact that they've always been light sleepers, but the reason why they've always been light sleepers is because it's an underlying issue that we haven't really dealt with as well. So that's why the comorbid sleep issues is important, because if they come in snoring, I want to make sure that they don't have sleep apnea that's manifesting as insomnia. If they have restless legs, at times their sleep apnea may be worsening their restless legs. If they're a nephrology patient and restless legs is causing a lot of the issues, are their ferritin levels adequate? So all of these things are important for us to kind of figure out if it's something that's affecting their sleep. Shift work is something you go into as well, especially if they tell you, well, doc, I can't really tell you what time I really go to sleep and what time I wake up because I do all of these things. So that's when you have to kind of tease out their sleep wake cycle to see what you can help them with, and then maybe not fight every battle, meaning that, when they do have shift work, how do we figure out? And that's something we'll discuss in circadian rhythm disorders, which is the 5th installment of these webinar series. And that'll take place sometime end of April, early May. But we'll talk about how to deal with shift work at that point. Medications, again, how medications affect our energy levels, our mood, our ability to fall asleep should also be addressed and assessed. We use the Insomnia Severity Index, and I'll be lying to you if I say I use this for every insomnia patient. I would use it in patients who have pure insomnia and nothing else to track their progress, but most of the time I don't. But I think if you're learning and trying to understand or work with insomnia patients for the first time, I think it's a reasonable tool to use to kind of help guide you and kind of act as a gauge for your patients. How do you then, beyond evaluating or taking a history, I find sleep tracking, whether you're using a Fitbit or whether you're using a sleep diary such as this, you can download this from the American Academy of Sleep Medicine. They have a PDF. Actually, you just Google ASM sleep diary PDF and you should have one. It's pretty rudimentary. It's easy to use. But if patients have Fitbit or they have something more, a newfangled gadget, and they can show that to you, that's fine. What I find helpful about sleep tracking is that the visualization of their sleep and the consistency of what time they go to bed and what time they wake up and the variation that occurs all the time. Like as you can see over here, for example, this is what time they fall asleep. If there's like a 2-hour gap, that's when you can sometimes ask them, hey, why are you going to sleep at this time when you actually have a problem? When you're actually going to bed you're falling asleep at 1 o'clock, why are you going to bed at 11 o'clock? So these are some of the questions that you can address when you visualize this with the patient. So it's really helpful even for the patient, because they're struggling in the trenches, and sometimes because they feel that's a very personal thing they've dealt with, they think they know it more, and so sometimes visualizing it helps them understand, like, oh, okay, that actually makes a little bit of sense. I can understand why now. And that's when sleep restriction is a therapy we'll talk about in a little bit, how that's helpful for us to kind of help patients get to bed and fall asleep quicker. The physical exam now, in all fairness, I do a lot of my evaluations now via telemedicine, so I can't say that I actually do a physical exam. I use the exam that's sent to me in the referral document as my surrogate exam, but you'll find that most of the time it's a good history, trying to get a sleep diary or visualizing what their problems are. So if you see a patient, talk to them, understand what the issue are. You might want to send them home with a sleep diary, see them back in a few weeks and see what's going on with them. A neurological screen, for example, if they have depression or mental health issues, is also important as well. Sleep tracking devices, I like engaged patients, but sometimes if you have insomnia as an issue, some engaged patients have the same sort of, I need to control my sleep issues thought process, which actually is counterproductive for actually getting good sleep, which is a state of actually letting go and falling asleep. You don't try to get to sleep, which is what some of us say. But the falling asleep part is where you actually letting go and actually taking over, letting the process take over. So sometimes if you're too engaged in the process that I need to do all these steps before I fall asleep, I need to make sure this is right. I need to make sure my temperature is at 68. I need to make sure I have this special mat that cools my back or my legs. I need to have this special pillow. Sometimes that can be counterproductive, because when they go to bed and they don't get the sleep immediately, that increases their angst. So that's why trying to match their sleep or when they fall asleep to when they actually or when they get to bed or when they fall asleep, matching those two processes helps, so that they don't have that angst as they're lying in bed, tossing and turning, going, oh my God, this is another one of those nights that I'm going to be awake, and so on. And that actually is counterproductive to sleep. Caffeine. Now, a lot of patients I like my coffee. I'll drink my coffee in the morning. I may have one in the early afternoon, but I know full well that after 2 or 3 o'clock, it sometimes does affect my sleep. Now, when you're younger, you can get away with a 4 to 6 hour window of how effective or the effectiveness of caffeine. But as you get older, if you're taking medications or if you're pregnant, you will find that caffeine can linger in your system way longer than the 6 hours that we think it does. So look into that as well as a potential cause for insomnia. This is one battle I try to avoid fighting with my patients. It's kind of like that battle that I have when someone comes in and they're already on a benzodiazepine, when they're already on opioid. I don't try to take their medication away the same way I don't try to take their nicotine away from them. If I feel that the nicotine may be affecting them, I let them know that it might be an issue, but we're going to not address that at this point, because nicotine also has a relaxing property. So at times it may be something you don't want to take away, because again, if you're taking away something without actually showing that you can actually deliver value, the patient's going to lose trust in you. They don't want to listen to you. So you have to be able to deliver value to the patient before they trust you and say, okay, I'm sleeping better, I'm feeling better, my drive or my craving for nicotine isn't all that much. Maybe it's time to kind of cut down, or that, I'm sleeping better, so maybe I can skip my benzo or cut my benzo dose in half today, or cut my opioid dose a little bit more, because I'm actually not feeling as much pain because I'm getting good sleep now. So this is one battle I try to avoid fighting. Now, if I've got my pulmonologist cap on and I have someone with bad COPD, then it's something I will address with them as well. Sleep and eating. Some patients like to sleep on a fuller stomach. Again, you try to advise them on what needs to happen. Again, they come up with this whole concoction of what they need to do before they sleep, and sometimes taking a snack. Again, it depends on what time you have dinner before that as well. Some people have a dinner, so they have a supper. Just make sure it's high in protein, which helps and reduces the episodes of reflux in a lot of these patients, because the digestive system does slow down in sleep. What about exercise? I don't discourage patients from exercising. Now, if I have a patient who exercises late into the night and they says, well, every time I exercise, I can't go to sleep, then well, fine. Try to exercise a little earlier. But if they're doing something healthy, I love for them to do something healthy. You can also look at the timeline of when the sleep or the insomnia was being affected. So if they've been exercising for years and the insomnia is 2 months, or they're going on for 6 months, then I try to avoid saying that, well, you shouldn't exercise. All I do is just make sure I note that down in my note and then address that at a later point if we continue to have problems with sleep. Diagnostic testing, unless of course in your differential there are other issues at hand. So that's why I mentioned earlier about insomnia with restless legs, and insomnia with things like how you feel at night, and whether it's your hormonal level, whether you're going through menopause, whether you may have sleep apnea. So those testing should be focused in patients that you have a differential diagnosis on, that may actually say that it might be something else. So that's when you kind of also evaluate that. You don't really need a sleep study for that, unless of course you're looking at other comorbid sleep issues. So we've covered the pathophysiology of insomnia, the circadian drive, the sleep drive in patients, the effect of it on our patients, the consequences, daytime consequences, the health consequences. And we've kind of touched on the evaluation of patients, how they come into your office, how you speak to them about, or you ask them questions about when this started, how long do they, how long does it take them to fall asleep, what time do they wake up, how do they feel they wake up, what sort of perpetuating factors there may be, what medications they're on, what sort of consequences they have. And so these are all evaluations that you look at. So I'm not sure. Oops. I think someone maybe, I think with their iPad and so on, maybe touching on the screens. I'm not sure whether you all can see that, but I can actually see all these lines coming up here. So I apologize for that. But let's go deep dive into now, how do we actually help our patients and start actually administering some treatment that works alongside some medications as well. We spoke about the cognitive approaches, where we try to figure out what the underlying causes, and this is what is within the purview of a lot of psychologists or sleep therapists. We try to understand what the issues are, what the thought process are, what the myths are, what sort of fixed ideas they may have about sleep, and how to kind of unfold that about. And this effect, a lot of it is patients with also fixed ideas during the daytime about other aspects of their lives and so on. But this is well beyond this. But I just want to kind of give you all an idea of what cognitive behavioral therapy as a whole is. And so it is time intensive. It's weekly sessions that go on for sometimes a month, 2 months, 3 months, sometimes a lot longer, depending on how effective it is. They talked about how the mind affects your actions and your affections affect your mind. in terms of your ability to sleep. Now, we will kind of go into more of the behavioral aspect of therapy. This is something that we can do in our offices without having any specialized training. And we can also see that how it affects our ability to kind of, how CBT actually helps us in terms of our usage of medications to help these patients. So it has lasting improvements. So even when you stop it after 3 months, and like I said, we do prescribe a lot of this e-prescription of these apps. We work with one of them. So what happens is we have patients who will end up getting these prescriptions easily, and then they start the therapy. And if they don't have access to sleep therapists, it works very well. I have a dashboard that I can see how they progress through, and if there's any issues, I get feedback right before the next visit as well. But I think it's something to consider in all of this. Since now we have smartphones and we have an ease of delivery, we don't actually have to try to deliver CBT on our own. Now, I'll talk about the behavioral, the brief ones after this as well. So like I mentioned, the behavioral therapy is something that the apps as well do. So that's something that we can do. Individual and group sessions are done by sleep therapists. Now, the behavioral aspects of it, the two that I use the most often is stimulus control and sleep restriction. Relaxation therapies, I think, is somewhat helpful. There's some aspects of it that I use frequently, that I tell patients frequently. Sleep hygiene is something that patients probably have already come across online. They already started doing it. They're switching off their phones. They're not, having coffee at 10 o'clock at night, and so on. So these are some aspects that we can look at. Now we'll touch base on the CBT. Oh, actually, we have spoken about the CBT and how that works, but we'll talk about the brief behavioral therapy when you put some of these behavioral therapies together, and something you can administer easily at your office. So stimulus control, that's the first part of the behavioral therapy, maintaining that sleep-wake cycle. Now, one thing I want to tell you is that if there's one thing you remember from this is try to ensure that the patient has a very routine wake-up time. We try to set it up as I need to fall asleep at 10 o'clock, so that I can have my 8 hours of sleep when I wake up at 6. That isn't actually how you want to start this process. What you want to do is make sure that the patients they set the wake up time, because the wake up time is going to dictate when the circadian clock starts. It also sets up their awakening time and also starts increasing the sleep drive, so that by 16 to 18 hours in the day, so you wake up at 6, by 10 to midnight at maximum, you're going to be feeling sleepy and really falling asleep at that point. Not really to try to fall asleep at a specific time, but making sure that we work in a backwards manner, meaning that they set a wake up time. So ask a patient, what is the time they would feel comfortable waking up? What is the time they would like to wake up? And that's when you say, okay, that's where we're going to stick the flag in there, and that's what we're going to wake up. Now, regardless of what time they fall asleep, that's the time they're going to wake up. The concern with this therapy is that they shouldn't be doing anything that requires hand motor coordination, heavy machinery operation. Someone who's got hypomania or mania as an issue, and sleep deprivation may cause issues. Some patients with very poorly controlled seizure disorder. I'm not just saying any seizure disorder, but poorly controlled seizure disorders. You don't want sleep restriction, or at least trying to reduce the amount of sleep time to or actually trigger a lot of these other medical problems. But what you will tell them is on a weekend, I tell my patients, you start this on a weekend, you start this on a Friday night, you set your wake up time, and you wake up on a Saturday morning at that point. If you go to sleep at 2 o'clock, you still wake up at 6. You will stay awake, do things that are active and so on, making sure that you tell your spouse or your bed partner that what's going on, so that you're not doing like driving and so on. Try to avoid taking naps during that day. And I guarantee you later on that night, you are going to hit your 16-hour window when you are about to fall asleep again. Now, to make sure that you wake up at 6 o'clock again the next morning. Now, do this for 2 or 3 nights, and you will find that these patients will end up falling asleep at the appropriate time that the body feels necessary. And that's why you want to avoid napping, because that takes away sleep drive. You want to tell them to go to bed when they're only sleepy, so they're not in bed worrying about the fact that they can't fall asleep. Now, they fought this battle for years. So as soon as they hit the pillow and they're not asleep within 10, 15, 20 minutes, they're like, man, this thing sucks. It's going to be another night when I'm going to have a lot of problems. I am not going to be able to sleep. Tomorrow's going to be a crappy day. And so these thoughts actually, instead of putting them to sleep or actually relaxing them, they end up having issues and they end up staying more awake. So stimulus control is something that I use very, very frequently, and it marries together with sleep restriction, which is trying to match the time that they actually are asleep with their time in bed. Meaning that if, hey doc, I go to sleep at 10 o'clock, but I never fall asleep till 11 o'clock, then what you're going to do is tell them to get into bed at 11 o'clock. And the hour before that they were used to watching TV and doing all these things, is to kind of unwind themselves, relax, not do anything that actually increases their angst or increases. Don't plan the next day. Don't worry about what your mother told you. Don't, or you're nagging, or the fact that you've gained weight, or the fact that you'd hate your boss. 10 o'clock at night is not the time to worry about that, to disengage yourself. But instead of falling or going to bed at 10 o'clock, is to go to bed at 11 o'clock and matching that sleep time with the bedtime. And so that when they do hit the pillow, they're less likely to have that angst of not being able to fall asleep.
Excuse me. So it's 10 minutes heads up.
Okay, thank you. And that's why sleep diary helps as well for the sleep restriction, because it gives you an idea of what time to tell the patients to go to bed. Relaxation therapy. Now I left this image over here because I thought it was funny, because it's not what I'm telling you all to do. We'd all like to get a massage before bed, but not all of us can get it. What I find is most helpful is with the stimulus control, which is that wake up time that you set, and making sure that you don't nap, and making sure that you go to bed only when you're sleepy, along with the sleep restriction that we just spoke about, is to ensure that when they get to bed, that they have the highest chance of actually falling asleep. And this is when you disconnect, or you reduce the somatic tension. Because as nighttime occurs and these patients have been dealing with insomnia, guess what? The anxiety increases. They're like, oh, I hope it's not one of those nights. I hope it's not one of those nights. I hope it's not one of those nights. And so that anxiety increases. And then as soon as they hit the pillow, they're like, it's one of those nights, it's one of those nights, it's one of those nights, and toss and turn. So what you're trying to do with relaxation therapy is actually disconnect that, or try to reduce that somatic tension. What you can do is abdominal breathing. I tell patients, this is just, it's like meditation. All you do is just take deep breaths. You inhale, you exhale. Your mind will wander. You bring your mind back. Inhale, exhale. I try not counting, because I get frustrated when I lose my count at 20, 25, 28, 30, or whatever number it is. So I just focus on taking slow, deep breaths, and your mind will wander, bring it back. Wander, bring it back. Don't get frustrated with the fact that your mind wanders. Your mind is supposed to wander. Just keep bringing it back. So the abdominal breathing is something that I find a lot of my patients I helped with. Progressive muscle relaxation is kind of a cool technique that I also use with the abdominal breathing, where you just get them to contract their toes first and then relax the toes. So contract slowly, relax slowly, contract your calf muscle slowly, relax slowly, contract your thigh muscle slowly, relax slowly, your abdominal muscle. So all you're doing, and you're marrying this again with abdominal breathing. You're doing this, you're contracting, you're taking a deep breath, and you're exhaling. And then you go all the way up to your neck or your head, and then you can go down again and up again. And so that's kind of reduce some of the somatic tension. So I use a relaxation therapy in concert with a lot of my sleep restriction and my stimulus control. Sleep hygiene patients have perfected, or they're pretty good at it at this point. So even the AASM guidelines now say that you really there's no efficacy in this alone. Now, of course, if someone is taking caffeine at 8 o'clock at night, they can't go to sleep 2 hours later, then it's something that they should rectify. But hopefully they're not in your office with this as a main problem. Brief behavioral therapy, this is something you and I can do, and this is what I do in the office, and that's why this whole talk is about, is just to kind of bring together stimulus control, sleep restriction, and some relaxation therapies together, and kind of do that for patients and give them some tools to be able to fall asleep better. So reduce the time in bed, so that's sleep restriction. Get up at the same time every morning, that's stimulus control. So you're trying to increase that association between bed and sleep. Don't go to bed unless they're sleepy. So even if their partner is falling asleep at 10 o'clock, they may need to get to bed a little later when they really feel sleepy, because their partners may be out there, maybe working, maybe doing more manual labor and really exhausted. And they may be in office-based practice or work. And so their sleep drive is a little bit different. And if they can't go to sleep, try to disengage from the bed, go do something boring, uninteresting, read a magazine, some tabloids. Don't read anything don't read anything political, please. And then try to get back into bed when you're feeling sleepy again. So that's brief behavioral therapy, which any one of us can do. Now, we have to recognize our patients live a normal life. They have issues, whether it's pain, whether it's a disruptive bed partner, whether they have caregiver responsibility, whether they have a newborn at home. Holy wow. I have a newfound respect for caregivers at this point. Pets, children, all of these things. So you have to work with them and explain to them, yes, we understand. And we just want to show you what you can do. And when you're ready for it, this is what I want you to start doing. Now, prescribing strategies we'll discuss very briefly. Now, the reason we're not offering any pharmaceutical points on this. They have the American Academy of Nurse Practitioners have a different thing for when we're talking about pharmaceuticals and so on, is that everyone will have their own little favorite drugs to use. I'm going to kind of go through a quick one of all the drugs that are available. And it depends on what you really are comfortable with, what you were trained with, what you've been using longer. Hopefully it's not what the drug rep bought you for dinner most often, or lunch more often. That's what you're prescribing. But reality is reality. And so the drugs for insomnia, the frequent used ones are the Z drugs, or the drugs that we frequently think about, like Ambien, Lunesta, Sonata. These are medications that can be used for sleep initiation. We have a whole host of drugs as well, which we'll talk about. These drugs, generally, you will find that they're all short acting. The onset action is quick. So most of them are also indicated for sleep onset. Lunesta has a slightly longer action, so they may be given for sleep maintenance insomnia as well. We will find that for Ambien, extended release is also given for patients who have some sleep maintenance issues. Now, like I said before, you don't want to leave your patients hanging in the air and struggling with sleep, and then you're going and talking now about stimulus control and sleep restriction, and I'm not going to give you any medications because I'm going to go through this. This is what I heard from Dr. Bhar, and I'm going to go through that. Your relationship with your patient is a personal one. And I'm not here to stand in the way to tell you what you should do and what you can't do. But understand the realities of care is that at times the patient will come to you with problems and they want to fix. They're frustrated. They need help from you, and you cannot leave them hanging. You can use medications. I just want you to set the roadmap for the patient if you have the opportunity to. Set the expectation, say, this is what we're going to give you the medications for, but I really want to work with you on all these things because I don't want you to get addicted to it. I don't want you to use it in long term. I don't want you to feel, because I think patients, when they go through insomnia for long periods of time, they feel like they cannot sleep. They've lost their ability to fall asleep. So all these thoughts about behavioral therapy is to increase their belief, their self-belief that they can actually sleep by tweaking their schedule, by making sure there's some therapies that you can initiate, but also understand that you can give it as a parallel path with medications so that they do get the help they need, and then you can work with them along the way as well to get them off the medications. Drugs for insomnia, can they ask questions? I'm worried about getting addicted to it. Sometimes they're already on it. I don't want you to take it away. So each patient is a little bit different. Will they become addicted to it? Maybe. The Z drugs like Ambien and so on are less addictive, but it's just more of a dependence on it. And you want to avoid that, especially as patients get older. You deal with a lot of issues of falls and dizziness and so on. We have benzos that we use frequently. I think I like, out of all of this, I like the triazolam or the Halcyon, which is the shortest acting in a lot of these patients. They have the least side effect profile in terms of sedation the next day and so on. Again, you want to use drugs that you're comfortable using as well. So I'm not going to recommend anyone that I would use. I just like the shortest acting because it gets out of my patient system. And when you are giving these medications, do another thing as well. Recommend that the patient start it on a weekend so they're not working the next day. To take it so that they can feel how they feel, make sure that they're not getting in the car and driving, taking their 45-minute commute at 6 o'clock or 6:30 in the morning while they've taken, temazepam for the first time, or when they've taken Ambien for the first time as well. Ramelteon is another drug you can use as well. It's a melatonin receptor agonist. We use melatonin pretty frequently as well. So this is a receptor agonist, is a brand name, is reasonable. Sometimes when I have patients struggling, I might try this as another tool in my kit. Doxepin is it's a H1 antagonist, and it's indicated difference compared to the other drugs I talked about, like the Z drugs, is specifically indicated for sleep maintenance. So you can try 3 milligrams or 6 milligrams, but just be aware of some of the side effects, the sedative effects the next day. But I've had patients who've had, I wake up in the middle of the night and I don't know why, and I've ruled out all other reasons. I've asked them about restless legs. We've gone through the sleep evaluation, sleep apnea testing, and they don't have that. For example, looked at medications that they have, reflux, and you ruled all of that out, and that's when you start giving these medications for sleep maintenance insomnia. Belsomra is a new one in the market. The one that works is the 20 milligram dose. So you start off at the 10 milligrams and you increase it 20 milligrams, though the side effects also increase. So like any drugs that you give, it's always a balance of risk, benefit. If the benefit of it is great, then explain to the patient what the risks are. Again, make sure they don't start it on a weekday when they're working the next day or have anything to do that requires driving or operating heavy machinery. Off-label prescriptions. Now, These drugs are all over the place. They use that all the time. I just want you to be aware that when you give these patients these medications, that we need to also understand what's driving the sleep issues. So start that evaluation even before you give your Z drugs, your benzos, your off-label prescriptions, is to find out why this 55-year-old woman sitting in front of me in the office has insomnia as an issue. Before I say, hey, try trazodone, I'll see you in 3 months. So you have to make sure that these patients, you go through, at least do your due diligence, please. Every drug that we give is a chemical that we're introducing to our patient's body, a potential for a side effect, a potential for interaction with other drugs, a potential for harm. It may be a quick fix, it might get them out of your office quicker, but you have to take the responsibility of making sure that you evaluated what's causing this, and making sure that even though, yeah, I need to give this medication, I also am obliged to ask you these questions so that we can figure out if I can get you off these medications or keep the doses to a minimal, so that that minimizes the side effects as well. The Benadryls, use it if you feel it helps you for short acting or acute insomnia. Now, if someone needs it long term, again, same thing with the off-label use of medications, try to figure out what's causing it. There's a reason why CVS and Walgreens has a huge long aisle of this. They don't really work. So that's why there's so many variations of it. The one drug worked, then everyone will just buy the one drug. But there's so many different versions of it, and patients do need it. I use it when I come off a night shift and I need to get to bed. I don't like how I feel when I wake up with it. And I can't imagine someone using this long term. Alcohol, it helps you fall asleep, it knocks you out, but it gives you very disrupted and fragmented sleep. Natural remedies, I really don't mind this, except if they start affecting the medications that the patients, the prescription medication they're on. And don't forget, a lot of these medications will affect, may have interactions. So just be aware of that. I try not to stop them from taking, especially if it works. If it works for them and say, hey, doctor, what do you think about melatonin? I say, just make sure you get it from a reliable source. Make sure it has the good pharmaceutical practice logo stamped on it. Make sure that you take it, you buy it from a reliable source, not just anyone selling it online. And if it works for them, I try not to take it away from them, especially if it's working. Who am I to decide what should work and what shouldn't work for the patient? Combination therapy works really well. So try CBT, like I talked about, with the medications, and it does reduce your doses of the medications. Don't do either one alone. It's not as effective. All right. Folks, that's more or less a wrap of what we've talked about: the pathophysiology, what causes it, the perpetuating factors, the precipitating factors, the circadian drive. We've talked about the sleep drive in a lot of these patients, the consequences on your patient's health, to make sure we think or plant the idea in your head about how sleep is affecting a lot of your patients and how we need to address that to improve all the other patient outcomes that we have. We've also discussed some of the toolkits that you can use, how to evaluate the patient, asking them about what sleep complaints they had, what sort of daytime consequences they have, how or what time they go to bed, what time they actually fall asleep, what time they wake up, how do they feel when they wake up, what wakes them up in the middle of the night, what have they tried before this, what medications they're on. So all the evaluation, and then deep diving into the behavioral therapy. The cognitive part of it, you can send them to sleep specialists. Like I said, we do CBT via our e-prescriptions that work beautifully. But you can, in your own office, start doing brief behavioral therapies, which include stimulus control, which is the wake up every day at the same time, avoid naps in these patients, avoid going to bed unless they're sleepy, matching their sleep time with their bedtime. So that's sleep restriction, teaching them some relaxation therapies, and trying to do that quickly in terms of, and once you start with this, again, there'll be a video recording of this when we send out the post-test webinar, the post-test for the webinar. You can watch this again. You may be uncomfortable doing it the first few times. Try it. You'll get more comfortable with it. Try it for the first few patients. See how you feel. The behavioral therapy. And then we discuss the prescription therapies as well and what you can do for your patients. Whew. All right, that was a lot. Now, understand insomnia is a disorder, not only and a symptom as well. It can affect your patients in many ways. I'm thankful for the American Academy of Sleep Medicine for all their clinical guidelines and their frequent journal articles that we read and so on, which helps kind of shed more light on sleep and issues. And we have our next webinar coming up on the 17th of March. So a month from now, we're talking about sleep apnea and evaluation and testing in patients that what we consider atypical typical patients, and then what sort of tests is important for them, and also the future of testing. So there's a lot of cool testing coming up now, which is smartphone based as well, which is FDA approved, which we do as well. So getting patients the treatment, because a lot of times patients don't want to get treated because it's a pain in the butt to get the sleep study done. Excuse my language. So please circle the dates. And I actually had a question as we're going to end off now as well. If y'all could reply back in your text box, would y'all prefer a 12:30 start time on a Wednesday, or do y'all prefer a Saturday start time at 10:30? If you could just reply back 12:30 p.m. versus 10:30 a.m., or you can reply back Saturday versus Wednesday. We might change the next webinar to match that as well, because we find that at least in terms of getting the knowledge out about sleep, we want to make sure we match that with what your schedules are like. And I don't want to dictate that. So if Saturdays work better, just click in the box saying Saturdays, or if you feel Wednesdays, then we'll do Wednesdays. All right, folks, I am ready for questions. Do you have any for me? And if you don't, we can end this webinar pretty soon.
There was a question on does the light emitting, 1 second. So there was a question in the chat. Does the light emitting glasses, do you have any opinion on it?
Maybe, I think it's like the same thing with the exercise problem that I have. If you think it's something that's I've started looking at my screen, I'm doing this more often, and you match a timeline with your sleep issues, then I think using this blue light blocking on one of the screens may be helpful. But again, each patient is going to be very individual. Some patients melatonin works like magic, and some patients melatonin has got zero effect. So it's something that I don't routinely prescribe, but it's when I speak about their bedtime routine and what they're doing about that. And if they say, well, I'm looking at my phone, I'm looking at this. And if it's like, well, I'm someone that has to check my news networks before, I may recommend that as a potential use, but I don't think it's I don't think it's a silver bullet, and I don't want my patients to pay for something that I am not sure about the effect on. But I will tell them that it's something to consider if they are someone that uses the screen very often, and even late
I think the question was more on the glasses that emit light to advance or to delay sleep rhythm, not the blockers, specifically about Pegasi glasses.
I don't really have an opinion about that. I think these are newer tools that I think it is going to be very individual to each patient. I have a very hard time believing that any of these things actually help with one tool and so on. I think a lot of us hope there's something they can use. Now, if you've tried different things and it works for your patient, then so be it. I would be lying to say if I had an opinion of that. Day and night confused. So someone asked this, I suggest some of these things for elderly dementia patients that get day and night confused. Is there anything else to help this population? I think that the sleep-wake cycle, the medications they're on, especially as we're elderly, is huge, because a lot of the drugs that we have, a lot of the data that we have on drugs is used in very what we call clean patients, patients who don't have a lot of medications on board, patients who end up, who are healthier generally. And so they get approved, but as you start hitting 65 and above, your cytochromes that actually break down a lot of the medications and so on actually slow down. Your interaction between drugs are worsened. So I think in the elderly, it is making sure that their sleep-wake cycle is correct, make sure they don't take too long naps during the day, looking at how their medications affect their sleep cycle as well, along with the fact that if there are any other confounding medical problems, obviously check their heart rate, check their anemia levels, making sure that the fatigue and so on is not anything else, but trying to look at all of that as well, especially when you deal with the elderly. I hope that was helpful. All right, looks like most people preferred Wednesday, so we'll stick with Wednesday then. Cognitive disabilities exhibiting restlessness. So pharmacological suggestions, I think that I would leave to the psychiatrist or the psychologist managing these patients. At that point, I think it's the off-label use of drugs. So whether it is an antipsychotic or whether it's one of these other medications such as trazodone or mirtazapine, I think those drugs are the ones that are stronger in terms of that. Using a benzo may be helpful as well if we think that there's a lot of manic episodes related to that disease. But that's going to be something that's very tried, very untried, very untested. So I think it's going to be very personal to each patient that's being dealt with. It's like I said, insomnia in this patient population, especially with cerebral palsy, is difficult, and I think it's going to be very individual how it's done. All right. Looks like we don't have any other further questions. We don't want to take too much more of your time, so we appreciate it. And the next one, like I said, is a month from now, and you will be able to reach out to us. Check out our website at sliiip.com. If you have any questions, you can also email me, and that's also another way to get in touch with me. Visit our website. There is a chat bot that you can ask questions on. We also have resources. If y'all are on, I see some of y'all are still on, so I'll go ahead and take the opportunity here to show y'all what we have. If my internet service would work fast enough. We have a whole lot of resources for people who wanna learn more, not only for themselves but for their patients. We give out free resources here. So there are blogs that we write frequently that you can share. I like this one that we wrote recently as well about over medicating our children. Looked at restless legs, how to deal with restless legs, how to manage restless legs. How to get patients to use pulmonary rehab. So we have a lot of stuff that encompasses the realm of pulmonary and sleep medicine. We also have then teaching videos that we do. So in terms of, if you want to share this with some of your patients, they ask, how do I take care of my sleep apnea or CPAP, the home sleep test setup, how does that actually work? I've created this whole bunch of videos here which actually talk about different aspects of dealing with issues that I found very helpful in my practice in pulmonary and sleep medicine. Things like, what is mandibular advancement devices for sleep apnea, how to deal with mask leak if that's a patient problem, how to deal with persistent sleepiness, even if patients on CPAP. If they don't love CPAP, well, not many people love CPAP unless they actually start using it and actually start sleeping well. But what are the issues? And I apologize for my handwriting. I swear to you, I try to write better, but I can't. And I apologize. But hopefully the voiceover helps you understand, how to look at some of the CPAP reports if that's something you're interested in. Bloating and flatulence on CPAP. Respiratory teachings, when to do a low dose lung cancer screenings, when to repeat a spirometry, things that they never really taught me in fellowship, but that I had to figure out on my own. What's the difference between a nebulizer and an inhaler? What is long-term oxygen therapy? How to look at a spirometry, how to read a chest x-ray. So these are all resources that we have on our website. And if you all feel inclined to, please share this with your patients, have a look at it. We'd love for you to share that with them as well. And if you have any concerns, any patients that you would like to send our way, you can download here. The referral form is over here. You can download that form and just fax it over to us or email it to us. If you're short of time and you're seeing someone in the hospital and you just want them to get some sleep evaluation because you're concerned about, their discharge instructions are going to be 25 pages long and they're not going to get a sleep apnea treated, or they're not going to get an insomnia treated, or their seizures are poorly controlled because of sleep issues. All you have to do is at the patient's bedside, just fill in the patient's first name, last name, the email address. If they have a cell phone, that will be helpful. Reason for referral, and actually the primary care provider's name and last name. So if you're a hospitalist or you're someone working hospital based and you don't want to have me harassing you for their note and so on and sending you their notes, you can just go ahead and put them primary care provider and we'll take it from there. But yeah, we've that's about it. I don't want to take up too much of time. See you a month from now, and hope y'all breathe well and sleep soundly, folks. Thank you.